Welcome to today's webinar. My name is Blake Baucom and I'm the Director of Sales for Osteogenics. Before we get started, let me address how we will be interacting today. From a technical perspective, we can't hear or see you, but we would love to hear from you and be able to answer any questions that you may have. There's a question and answer button on the right-hand side of your screen where you can type your questions at any time, and we will try to get them answered during today's webinar. Now let me introduce you to my friend Mel Vroom. Dr. Mel Vroom received his DDS from the Academic Center for Dentistry in Amsterdam in 1994. He also attended their Master of Science program in periodontology from 1995 to 1998. Since then, he has maintained a private practice in the Netherlands, which is limited to periodontics and implantology. Dr. Vroom is a national and international speaker on DPTFE membranes and has spoken at the Osteogenics Symposium, the AAP, and the Osteology Symposium. That's just to name a few of his accomplishments. He also gives multiple hands-on courses during the year and is a general secretary for the Dutch Society of Periodontology. Dr. Vroom, my friend, thank you so much for being here today. Can't wait to hear your lecture and be able to interact with you after. Thank you.
Thank you. Well, to start with this presentation, I look back. I look back at the 14 years I've been using this DPTFE membrane enriched preservation procedures. And when I look back, three words come to my mind: fascinating, predictable, and joy. And in this presentation, I will come back to these three words, and you will see they are related to this technique which I'm going to present today. Let's see if I can have the next slide. Yeah. Blake already told you a little bit about my background. So in 1998, I started to work in the north of the Netherlands, together with my colleague Lodewijk Groendeman, who is seen on the upper right. And what I'm showing today are our clinical cases, our opinion, and to be totally clear, we don't have financial shares in the company who produces this product. Well, let's get back to the GBR basics. And when I think of the GBR basics, I think of the study of Dalin in 1988. An animal experiment in which they created surgical defects. So first they lift up the tissues, they create a surgical defect, and then in the test group they apply a PTFE membrane and cover the defect. While in the control they used no membrane at all. And in both groups they again closed the tissues at the end. And what they noticed, or what they found, is that if you, let me see, if you go and see at the membrane side, you see almost complete defect bone fill. While in the control group, there's a limited bone fill due to the connective tissue ingrowth. So as long as you have a space secured, you will get this regeneration. And a few years later, a very interesting study came up from Professor Schenk, also an animal experiment in which they also created surgical defects. So again, they open up the tissues, they create the defect and covered it with the membrane in the test group. And in the control, no membrane. And of course, it won't surprise you that in the membrane group, they almost got complete bone regeneration. And again, in the non-covered membrane group, so no membrane use, there was limited bone growth. But also in this study, they used titanium reinforced membranes. And they were shown to keep their shape in a more reliable form. But this study also shows or tells us what goes on underneath such a membrane, the healing phases. And Schenk describes phases from blood clot to woven bone primaria spongiosa, and then to lamellar bone and bone remodeling and the formation of osteons. All those steps to occur. And about 3 years later, let me see if I can, the next slide, yeah. 3 years later, Professor Lang, in 1997, refers to this study of Professor Schenk, stating that this histological documentation, so the Schenk study, confirmed that bone regeneration in membrane-protected defects followed closely the pattern of normal intramembranous bone growth in extraction sites. So he made the similarity of a covered extraction socket. So let's keep that image in mind, a covered extraction socket. And also he states that the development through similar sequence of maturation steps occur. And what do we know about the well-known first PTFE membrane, the expanded PTFE membrane from the well-known Gore-Tex company who knew? Is it permeable to bacteria? Well, a study which gives an answer to that question is of Simeon in 1994. It's a human study. 10 patients are included, and group A, I call it the conservative treatment. So 5 patients, extraction, then they let the tissues heal for 30 to 40 days, and then they placed an implant and covered it with an expanded PTFE membrane, and they had primary closure. And after healing, the second phase was done after 3 to 6 months. While in group B, 5 patients were included, it was more the test group. They did extraction, but immediately placed the implant and covered it with an PTFE membrane. And of course, they had an exposure of this membrane. And the membrane was removed after 30 to 45 days, and then they let the tissues heal, and after 3 to 6 months, the second phase was done. And they looked at membrane characteristics and also the amount of regenerated bone which could be achieved. What did they find? They report that in group A, so you kept the tissues closed over the membrane, you have a lot of regeneration, 96%. While in group B, where you had the exposure, it was reduced considerably to 41%. And at the moment they removed the membrane in group B, they also looked on the membrane on both sides, and they found on both sides large amounts of bacteria. So really showing that the bacteria can migrate through the older expanded PTFE membrane. And also they state that exposure is a complication which can reduce the amount of regeneration. All things we found out in those early days of GBR. And of course, a lot of attention went from that time point to the resorbable membranes due to various reasons. But I will say in the background, the evolution of the PTFE membranes went on. From the upper left, the expanded ePTFE membrane, to 1994 a TEFGen, more dense version, and in 1997 the cytoplast dense PTFE membrane, and 1 year later the titanium reinforced version. But what's the main advantage of this dense dPTFE membrane? The main advantage over the older, well-known in the past ePTFE membrane. Well, the dense PTFE proved to be non-permeable to bacteria. And here on the left in the screen, you see a detail of the upper surface of this membrane with dimples in it, which calls the Regentex surface, which will stabilize the membrane as the tissues can adhere in a sort of way to it. And on the right side of your screen, you see fibroblasts growing over this membrane, showing that it's really well accepted by the tissues. Not really surprisingly, because of course PTFE has been used in general medicine for more than over 30 years. But today we're talking about ridge preservation. Why should we do or apply ridge preservation? Well, we all know the sites or the clinical views in daily practice. Here on the right, you see a tooth is extracted and we see a vertical loss. While on the left of your screen, you see more collapse of the tissues in horizontal direction, but also a shift from the mucogingival line from vestibular side to the more lingual side. And if we look at reviews, this is of course backed up with literature, like the review from Hammerley in 2012, a systematic review, and they looked after extraction, just plain extraction, after 6 months, what kind of mean resorption you can expect. When in vertical direction is 1.2 and the horizontal direction is more, it's 3.8. And Schropp shows in 2003 that after 1 year you have horizontal resorption about 50%. Let's have a look at some years ago. Around 2010, 2011, a whole bunch of reviews came out. And I just want to highlight one from a Dutch periodontist, Den Hegeler. In this review, she looks at various techniques for ridge preservation, but she uses a criterion that each study should have a control group. And the various techniques show various results. However, if we look at the discussion, she states that implant placement would most likely still need additional augmentation because none of the therapies completely prevented bone resorption. And then I start thinking, isn't that odd? I mean, we're applying a technique to build up the ridge, preserve, and still we have to do additional augmentation. Doesn't make sense. Well, the nice thing of having a referring practice, you see all sorts of patients walking in. A patient, for example, like this. Ridge preservation has been applied. The dentist placed the implant, but still we see a massive collapse of the tissues. So does every ridge preservation lead to the same results? We can wonder. But what about then the DPTFE ridge preservation technique? Well, already in 2001, Dr. Barry Barty described this technique, calling it the cytoplast DPTFE ridge preservation technique. And if we look on the left, I think we see a covered extraction socket. Keep that still in mind, so we know what the healing will be underneath it. More than 20 years ago, he has described this technique, and I think it's still remarkable how little attention has been paid to various congresses to this very interesting technique over time. So, what about this technique? First, I will describe it very briefly, and later on I'll show more details. But very briefly, you extract the tooth as gently as possible. You lift the tissues up around the socket, so you're tunneling in a way. Then you trim your DPTFE membrane and you tuck it under the tissues. And of course, on the drawing, it always looks easy, but take time, get trained in it. You place the implant and make sure that the edges are covered. So details are important. Then, after 4 weeks, you can take it out because we know from research that the osteoid matrix has formed. And then the epithelialization can go on. And about 4 to 5 months after you extracted the tooth, you can place your implant. But when we give courses, my colleague and myself, or presentations, we start noticing afterwards that participants easily mix up the indications of this membrane. So that's why we start using the term closed GBR on the left screen, and on the right the open, between quotation marks, open GBR. So meaning that on the left, the closed is the traditional. Tooth is already taken out some time before, and you have to restore the defect. So you apply the membrane, but you close the tissues afterwards. While on the right, with the open GBR, immediately after extraction, you cover the extraction socket with this membrane, and we apply mostly a graft in the socket. So you leave it open. As a kind of stable scaffold, you can place it in. So how did we run into this membrane, my colleague Lodewijk Gruneman and myself? Well, I think it was 2008, and we went to an implant congress in Europe. And we picked up a leaflet from the Osteogenics company, or the booth. And in the plain back, we looked at this leaflet and we saw a case of Dr. Barry Barty extracting a tooth and then covering the extraction socket, but leaving the membrane open. And we really looked at each other, my colleague and myself, and we were wondering, what is this guy doing? He's leaving the membrane exposed, something from our point of view very uncommon, because we all knew and were trained that with the older, the expanded ePTFE membrane, if you got an exposure, you were in deep trouble. But we got interested. And we start ordering this membrane and treated first small cases. Cases like this, tooth taken out, membrane placed, and here you see the clinical view after 4 weeks. And the tissues really look at ease. There's a little bit plaque on the membrane, but that doesn't matter, as we know it's non-permeable to bacteria. At that time, 4 weeks after extraction, we can take out the membrane. A nice property is from the membrane that it doesn't easily tear. It tears, it stretches more. But if you want to take it out, you will feel that the tissues will have some grip on the Regentex surface. So you have to apply a little bit of force. Don't be surprised with that. But does it make sense? Does it make sense to use this membrane after an extraction? Well, a study by Hoffman in 2008, I think, gives good answers. By the way, it's a study which is not included in the review of Den Hegler, as it has no control group, but still it's worth looking at. They include 276 extraction sockets. I think that's a good amount. They applied the DPTFE membrane with no reinforcement and no bone filler. And they looked at the bone loss after 12 months. And they excluded teeth with more than 50% bone loss, and the membranes were removed 28 days after extraction. And what do they report? Horizontally, hardly any loss, 0 to 0.5. On the vertical sides they lose some, but mainly in the center, which makes sense as they didn't use a bone graft and not a reinforced membrane. So it's the part where it's least supported. When we applied this technique in our technique, we saw a very positive effect of the amount of keratinized tissue. Because on the left you see the image when you just take out the membrane, the osteoid matrix you will see, and then we know the epithelialization will go on, and because the edges are keratinized tissue, it will increase the keratinized tissue. And so in 2014, we were really happy that Barbosa came up with a study which backed up this observation from us. And Barbosa included as a control 15 plain extraction sockets, while in the test they did 15 extraction sockets and covered it with a DPTFE membrane, non-reinforced and also no filler. And they looked at the keratinized tissue in horizontal direction. Baseline versus 90 days, removal again after 28 days after extraction. And what did they report? An increase in the control group, so the plain extraction, a mean of 1.4. But if we look at the test group, there was a larger increase, 6.6, something we also noticed, that you have a really good increase of keratinized tissue, and as I often say, you get a luxury amount of it. But giving presentations also pops up the question, what about the barrier function? Not surprisingly, because we all were trained or had the experience with the older expanded PTFE that when it is exposed, you were really, really in deep trouble. So people have to get used that this dense PTFE can be exposed. And then I always show the study of Laurito. Laurito in 2060, 10 patients, the DPTFE rich preservation technique, and at 28 days, they removed the membrane and looked immediately at the tissue underneath the membrane and investigate this. And they report no epithelial cells or no bacterial contamination. So the barrier function works. As long, as I always say, as long as the edges are covered, of course. That's a detail which I'll emphasize later on. So what about indications? Well, I think there are various. Of course, conditions which have to be met is that the tissue should cover the membrane edges. No root embrasure, because then you don't have tissue to cover the membrane. And also you don't have enough support from the membrane when you place it. And I think you can wonder if the original ridge width is 6 millimeters or less, does it make sense to apply this technique? But as we were applying this technique, we saw such a nice results that we moved on to more challenging cases, which I want to show to you to really illustrate the potential of this interesting technique. For example, a patient like this. I treated this patient more than a decade ago. 2 molars which have to be extracted. The first molar, the patient wanted an implant. And on the right of your screen, you see the cone beam details and you see a lot of bone loss due apical surgery. So we decided to extract the both molars. In the first molar, apply a bone graft and also a titanium reinforced DPTFE membrane, because we wanted to have as much support as possible. In the second molar, we only place a collagen sponge. After 6 weeks, I left it in longer to have more support because there was so much bone damage. On the left, you see the clinical image. You see the titanium reinforced strip. In the middle of the membrane, take out the membrane. We have a little bit bleeding, but that easily stops. And at those times, we really wanted to show really find out what amount of material was regenerated. So that's why we took a local cone beam. And on the left, pre-extraction, and on the right, you see about 5 months after extraction, and you see the repair. And we also wanted to know where the flora of the sinus was. So we could place the implant, the upper left. The referring dentist made the crown, and the x-ray you see after crown placement, and the one which pops up now on the right is the x-ray 4 years later. And if we have a look at the clinical view, we see on the left upper and lower crown placement, and on the right upper and right lower you see the crown after 4 years, and of course you see the wear. But let's look at details. These 3 slides I really like. I tell you why, because it's linking science with daily practice. That's what I really like. On the left side of your screen, you see the second molar at 6 weeks and the tissues are already collapsing. We know from the review of Hammerle that it will continue. On the right, you see the membrane is just taken out and all the borders are keratinized tissue. So all the tissue which is now reddish, the osteoid matrix, will become keratinized tissue, as we know from the Barbosa study. And from literature, we know that if you take out a tooth, a whole cascade of healing events is going to occur. As you think about it, kind of natural regeneration wave. Well, why not apply the bone graft, apply this dense PTFE membrane, titanium reinforced, and in that way serving along this regeneration wave and using the membrane as a stable scaffold, really guiding this wave in the direction we want. And look at this case more in detail. Is it ridge preservation? I don't think so. I think you call it ridge preservation / restoration and improving the amount of keratinized tissue, because that's what this technique delivers time after time. And we go back to this clinical slide. Look at the second molar on the left. Crown placement already reduced and after 4 years even more reduced. And then look at the tissue at the first molar where we apply this technique and they are stable or white. A joy to look at. Now we go into details. I show you some techniques or just things to look at. First, if we extract the tooth, we want to make sure that all around we have tissue to cover the membrane. Then we take a surgical spoon, a Lucas spoon, and we start making the envelope, the tunneling. And make sure that you tunnel it very deeply, because then you really have space to place your membrane. Here also take care that if you make the envelope, also really do use the corners like seen here. Make enough space for your membrane. And while you're doing this, you can also feel where the bone loss is not. Then you take an Orban knife and you cut under the papilla and you check if you can lift the papilla up, because you should have space for the membrane. And also on the other side you can use this. This instrument you can also use for the corners, because sometimes with the Lucas spoon it's difficult to make the right angulation. Then we have 3 options. First we have the 12 by 24 non-reinforced, and you see here the upper part, the dimples, which should move up face up because they adhere to the tissues. And here we have the 12 by 24 with a titanium reinforced strip of about 10 millimeters. But if you have severely resorbed sockets, it won't do the job. So that's why we were really happy that Osteogenics made this size for us, the 12 by 30. And as you can see, the titanium strip is longer. It's about 80 millimeters, so it will do the job in severely resorbed sockets as we use it often. If you start working with this technique, you can, of course, with the paper first make a mallet when you cut the membrane to the right size. But you can also directly cut it. And then you're going to have a look and see, now it's too tight. There's not enough space. So first I always start cutting a point, kind of point shape from both sides to get it easier in the deeper part. Then we check again. And it's too tight, so we cut away a very little from the edge of the membrane. Take it easy and take your time for it. This is still too tight because you should be able to place it underneath the papilla. So that's a real detail you have to take care of. Here, this is better. You can move it a little bit and still it can be covered with both papilla. Now we're going to check. We see 10 millimeters occlusal. On the palatal, we have a bone up around 5 or 4. So we have a 4 millimeter on the palatal. We want the occlusal part to be 10. We see 10. We measure 10 and then we're going to bend it with a surgical tweezer. And make sure that you really bend it in a 90 degrees angle. So you really, what I call a kind of square U-form shape, to have a really stable scaffold. If you're done with this, you bend it open a little bit so you will be able to place one side of the membrane and later on the bone graft. There's various techniques, but I'll just show you a couple. Then you take your surgical tweezers and you place it in the envelope which you made with the tunneling procedure. You place it in and then you're going to check. Check if the membrane is really past the border, the bony border. And if you're sure you are, you can take the tweezer again and place it really deep. So you have stability of this membrane before you place the bone graft. And now we're going to apply the bone graft. We use always an adjusted syringe where we put in the bone, so you really can easily place it and have control. Normally it's of course bleeding. I always use a cotton gauze to really get rid of the excess of bleeding, and you can see where the bone material is. And then you condense it with the Lucas spoon, but take care not to overfill it. So always fill it up to where the original rich borders were. Now we're going to take a surgical tweezer and we're going to place it under the palatal envelope. And you push it with an instrument down. And because it has a kind of memory, it will go to the square U-form shape. And now the difficult part comes, because here you can see you have to lift up the papilla over the membrane. And this is a really detail. You can use the Mini-Me from Istron Urban for this. It's a really nice instrument. And you can really push it underneath and then push again on the edges to really get the U-form shape in it. And because this is a very important detail, I will show it again, this part. As you can see, we place it in. We use the instrument to push it down. And on one side, you see on the mesial side, it's already easily under the papilla. But on the mesial side of the molar, we have to push down the membrane a little bit. And because it's more rigid than the non-reinforced one, it bounces back underneath the papilla. And that's really handy of this membrane. Again, push in the square U-form shape that is really stable. And if you look at the membrane now and you push on it, you can already see even on this model, it's quite stable. But the edges should be covered. If you have a large bony defect, you can make a small flap. For example, here on the vestibular side. And then you can raise the tissues, make a mini flap, and then you can also have more access for cleaning and also for applying the membrane. But there are different options. I just show some. Another technique which you can use to really getting the membrane into this envelope is a kind of retraction suture, as I call it. So first you go from the palate to the inside, and your entrance point should be quite apically. Then you pick up the membrane and you go from the inside, the inside to the outside. Yeah. You go back to the palatal tissue and really again, very apical region, get the needle out. Then you're gonna take your needle holder and you get grip of both sutures. And you can pull in gently, or your assistant can do that. And here you see with the surgical tweezers, you can get it in and pull it in into the deeper part if you want to. What about suturing? Well, we often use a horizontal mattress suture, as you see here, to cover the membrane and to keep it also in place. And we use it with a sling, as you can see here. And now the difficult part becomes when you start using this material, this technique. Do not, I repeat, do not close the tissues. And that's hard because we're all trained to really start pulling and getting more closed. And in the beginning, it's a little bit scary. Can I leave it open, the membrane? Yes, you can. Just very little tension to it, because else you move up the mucogingival line. Sutures can be removed after 2 weeks or 4 weeks. The membrane is removed 4 weeks after extraction, and with the larger, severely resorbed cases, I would advise 6 weeks. And with this titanium reinforced version, if you use this, you can lift it up a little. You have to get grip of it, and then you can stick the periodontal probe through the membrane underneath the titanium bar or strip. And then it's very easy to pull it out, and mostly you don't need anesthesia for the patient. And you lift it out. And because we were having such a nice result with also the severely resorbed cases, we wanted to report on this. And that's why we conducted a pilot case series study, which I conducted with Lodewijk Grundeman and Ist van Urban. And we included really severe cases, because most studies exclude 50% bone loss or more. And as far as our knowledge goes, studies which have been done on ridge preservation with deep PTFE membranes, this is the first one to report on titanium reinforced version. 10 patients were included. Extraction of a premolar or molar, 50% or more buccal loss or palatal and or. So the really bad cases. With or without periapical pathology. Clinical attachment at the neighboring teeth was accepted, and 4 patients had a fistula. How did we treat these cases? We applied a mixture of allograft 60% and DBBM 40. We applied the 12 by 30 DPTFE membrane open GBR fashion. Membrane removal was after 4 to 6 weeks, and the baseline was just before extraction, so T0, and T1 was before implant placement. And we looked at various parameters like probing pocket depth, keratinized tissue, to name a few, but also bone changes, which we measured clinically. But also at T1, we looked at the horizontal bone loss by doing bone sounding, transferring these measurements to a stone cast model, which was made at T1. And this stone cast model was scanned and stitched to the baseline cone beam. So we're really measuring where the hard regenerated tissue was. Here are some patients. Patient from the study. Patient with a first molar has to be taken out, already a recession. If we look at the cone beam scan before extraction, you can see that the buccal wall is nearly totally blown out. We apply this technique, and on the left you see after extraction the membrane. We take out the membrane after 4 or 6 weeks, and then after around 5 months we can place the implant, which you see on the right. We have restored the bone, and clinically we also got rid of the recession. Or another patient from this study with a lot of decay and also bone loss on the buccal side. Here we see the clinical view, a cleft already, clinical attachment level on the neighboring teeth, Not a very tempting, not a very positive sight, but still it's tempting. So we take out the tooth carefully. You see the bone loss here on the buccal side. You apply this technique, and after 5 months, the fun part can really begin. We have a luxury amount of keratinized tissue, wonderful. We go and open up the tissue, and the joy is even more because we have fantastic bone. And I often say, now we're gonna do the real test of the regenerated material. We're gonna drill in it. And we've been using other techniques, but never you get the hardness of bone which you get with this technique. As you can see the next slide, really hard bone, sharp edges. It shows it. So what about the results of this pilot study? The mean bone changes in horizontal direction were minus 0.8, while in vertical we gained 0.2 to 2.8 millimeters, depending on the site. And the highest vertical bone gain, of course, again depending on the site, was 2.5 to 5.7. Keratinized tissue increased, so it confirmed the Barbosa study, and we have good implant stability quotums. One patient needed an additional augmentation at the implant placement. It was more due to an anatomical undercut in the ridge, which was present pre-extraction. If we look at other cases to show the potential, this is a patient not included in the study, was treated long before, but it showed that if you have an incisor with a lot of bone loss, no buccal wall, do apical surgery, etc., and this patient was, by the way, smoking 10 cigarettes a day. But with the normal 12 by 24 titanium, we couldn't have done the job. So this is a real case for this ANL30. As I showed earlier, we were really happy that the company made this. And the company called this the ANL30. And of course, you will agree that my colleague and myself said the A is for the advanced cases, and the NL stands, of course, for the Netherlands. But I'm not sure if Blake will agree on that. We'll see. Anyway, the same patient, at 5 months, we could place the implant. And here we see the final result. But now we go to even worse cases. Cases you will recognize from your practice. You will probably recognize this. You take out a very weak molar tooth. It breaks off. Roots are remaining. You have to lift the flap and remove bone because you want to have access to the remaining roots to get them out. And while you're drilling away the bone around these roots, probably you also have noticed there's a little voice in the back of your mind saying, I don't like this really. I am moving away the bone, which I have to restore later on. Probably a familiar feeling you thought. Well, to be frank, I've lost that feeling already more than a decade ago. Because with such a case, I can restore it. And after 5 months, if I'm opening up, I have wonderful bone. I have a luxury amount of keratinized tissue. And again, the word joy pops up. But maybe you're wondering, he's raising a flap. Well, in some reviews, they say you should not raise a flap because it has a negative influence on the buccal bone plate. Well, then have a look at the following study from Chesnoe Mate, an animal study in which they treated the extraction sockets with a deep PTFE membrane and in the control group no membrane. And they took out after 40 days this membrane because it was an animal experiment. And they found that on the covered, they sacrificed the animals at 8 weeks, if I'm correct. And they saw that the bone growth was outside the buccal plate when you applied this membrane. And this observation was also confirmed by a study in 2019, by Pessoa de Oliveira, which did also this study model, but closed the tissues to have more control of the membrane. So it shows that if you raise a flap with this technique, you can still have good results. And now pushing the limits even more. Look at this case. Bone away nearly everywhere. But we believe in this technique and we saw so many nice results. So we apply this technique, and after 5 or 6 months you have the bone and you can place your implant. In our practice, of course, besides the open GBR directly after extraction, we also apply a closed GBR, meaning the tooth is already taken out long ago. And if you apply the closed GBR, from time to time you will get an exposure. But because we got the experience with the open GBR, we start looking differently at the exposures when they occurred in the closed GBR. And we also looked at classifications, how to deal with them, and most of these classifications were based on the older the expanded PTFE membrane, or were not complete as to our opinion. So that's why last year a classification was published, which I together published with Lodewijk Grundeman and Pierre Gallo, which will guide you how to deal with it, but probably this can be an interesting subject for another webinar. If we're going to look at reviews, more recent reviews, I want to draw your attention to, I think it's a very interesting study by Barocci from last year. And they only include non-molars with less than 50% buccal bone loss. And in this review, they state as implications for daily practice that avoid flap advancements for healing by primary intention. So really it emphasizes the need not to close the tissues. They also state that consider a membrane as it will minimize the ridge resorption. And they say above $50 there's a diminishing effect. Well, they asked for these prices, of course, 2 years ago, and you won't be surprised that the Cytoplast DPTFE membrane without reinforcement at that time was $50. So it really shows in this review that it is a good membrane. And if you read a lot and also look at all those reviews, you get also sometimes personal considerations, which I like to share. Considerations like, what's the uniformity of sockets? I mean, if you have a resorbed socket, every socket has its unique characteristics, so it's difficult, I think, a subject to study. And I also wonder, hardness of the regenerated tissue versus ridge measurements. I mean, some studies are measuring on cone beams, but it doesn't say anything about hardness. That's what I like of this review by Barocci, that they also mention some studies which report that the regenerated tissue is rather soft, which you can have with other techniques from my point of view. And an interesting point, of course, is what's the effect of the titanium reinforcement? If you compare it with the non-reinforced, we don't know. I mean, this pilot study, as far as our knowledge goes, is the first one with the titanium reinforced, using it in the ridge preservation. But with all techniques, to be clear, and I want to show a really honest image or picture, you have a chance of complications. Complications with this DPTFE after extraction, I will call exfoliation or partial exfoliation of the membrane. Infection is sometimes mentioned, but if I look back at the 40 years, we only had one patient with an infection. And if I look at the Hoffman study and also another study of Barbosa I came up with more than 600 patients with this technique and no infection. But an example, patient treated here on the left, after extraction, membrane in place. On the right, 2 weeks after extraction, we took out the sutures. Nowadays I take them out later. But then another 2 weeks later, so 4 weeks after extraction, we see the exfoliation of the membrane. But then can you really call it a complication? I mean, you take out the membrane and then after 4 months, you still have the luxury amount of keratinized tissue and you can place your implant. And on the right, you see the implant crown after 3 years in place. But take care. Take care that if you use the titanium reinforced membrane, which we liked, as I said, it's easier to get it under the papilla because the papilla really should cover the edges. Make sure that you bend it in a really U-form square size and also mimic the sizes of the ridge which you want to restore and which it was originally. You can't overbuild too much outside the original form. And on the right, you see that you really make the edges deep enough that they really pass the existing borders. So make it preferably longer, that is really stuck under the tissues quite deep to have this stability and to minimize the chance of that it will exfoliate. So I come to conclusions, if it will work. Yeah, conclusions supported by literature. It makes implant placement much easier. A nice story to tell is that in the Netherlands, once a participant of hands-on came later on to me, a few years later, he said, thank you. I said, why? He said, thank you for showing me this technique. It made implant placement so much easier. It's indicated for all sorts of sockets, as I illustrated, with really worst cases to treat. And it will prevent a large sinus lift in the upper jaw or more complex GBR procedures down the road because you're restoring after extraction. It will increase the keratinized tissue. That's a very nice side effect. But also, I think a detail which should be emphasized, you get no shift of the mucogingival line. And there's hardly any need for additional augmentation at the implant placement. If we look back at the 14 years, we looked at it and we came out about 6%. But all the membrane, in all those situations, still the membrane, when we placed it, it was covered by bone. So I started with 3 words: fascinating, predictable, and joy. And those words have been illustrated in this presentation. So if I put it all together, I think this is a rather fascinating technique, which I'm sure will bring you a lot of joy in your daily practice. I thank you for your attention.
Dr. Vroom, I agree. Fascinating presentation with a ton of really good information and lots of clinical pearls that I'm sure our attendees and the audience will be able to use in their daily practice. So thank you so much for sharing your presentation.
Okay.
We've had some really good questions that have come in already, but I want to remind everybody the question and answer button there is on the right-hand side of your screen. So please, if you have additional questions, please feel free to type those in. We'll get to as many as we can here. Looks like we've got 5 or 10 minutes that we can spend here with Dr. Vroom. Of course, it's late in the Netherlands, so we appreciate you taking the time to do this for us here. But let me get into the questions. The first one is written from the perspective of the clinician. So let me just pretend like I'm a doctor, which I'm not. But when I have a buccal bone defect or the bone defect due to fistula, I was taught to use resorbable collagen membrane and then to cover that defect. And then I also use a PTFE membrane over the top of the collagen membrane. So what are your thoughts on that technique when we have a buccal defect or a fistula?
Yeah. Well, what I show is that in the pilot study, we include patients with more than 50% bone loss, palatal, buccal, or both walls. So there was massive bone loss, and for patients at a fistula. And what I noticed that when you clean it properly, place the implant properly, you have a very stable scaffold which will seal it off. And then when you take out the membrane, with the advanced cases, of course, after 6 weeks, there's no fistula. I always like to keep the material cost for the patients as low as possible. And of course, it's an investment, the cost at a rich preservation, but as we hardly need any additional augmentation when we place the implant, the costs are reasonable. But if you're gonna apply a collagen membrane, I will do. I don't see any point in it, and that's why I think to this participant, read the pilot study and see for yourself. It's now in the International Journal of Perio Restorative Dentistry, May, June. You can have a look at it.
Great, very good answer. So the next question then, do studies show better regeneration if surgical tacks and PTFE sutures are used, or is it okay just to use the sutures without fixating the membrane?
Yeah, the nice thing is when you use titanium reinforced membrane, besides from the easier placement with the papilla, because it's more rigid, it doesn't rimple so easily, which you will get with the non-reinforced. And if you use the technique which I showed you with the square U form, as I always call it, it's so stable. You won't be surprised if you place it in and you push on it. I mean, it's a really strong scaffold. It's wonderful. And you have your stable box which you want. And think it over in the presentation. I mean, you see the study of Schenk, also with what is going on underneath. Yeah, sometimes to patients, I always say that the membrane is a kind of temporary band-aid, if I pronounce it right in English, to cover the wound, because we are working in one of the most dirtiest parts of the body, the mouth, and we're doing a kind of orthopedic surgery. So really have a good seal, and that's why this membrane is working so well. So suturing the membrane, I will do. It's not necessary.
Okay, perfect, great answer again. So just to be clear there, as long as you can easily adapt the membrane, it's got enough support from the underlying bone and the bone graft, you really don't think there's a need for fixation pins or screws with this type of case?
Now, pins, not at all, because then you have to really raise the tissues or lift and make a flap again. So pins, not at all. So that's a no-go at all. And I maybe can think of situations when you're using a non-reinforced 12 by 24 that you maybe like to suture it for more stability. But probably you are treating challenging cases, and then why not switch to the 12 by 30? But we see a lot of examples of patients or colleagues using the 12 by 24 non-reinforced. And I hope with this pilot study that they also can see the advantages of using a more stable scaffold for better results, but I think also for easier placement.
Great, Dr. Vroom. I'll just tell you the questions now are flying in fast and furious. Lots of questions coming in.
Good.
We probably aren't going to get to
People
all
are
of them.
thinking.
Yeah, it's great. I mean, it's good interaction. I'll probably send some of these questions to you. We can get the answers, and then we can respond back to the attendees if you're okay with it. So let me ask a couple more. I know that your time's important, but let's see here. What's another one? Bone graft material that you use. Are you using allografts, xenografts? What material are you using for these cases?
Yeah. Well, as I said, with the pilot study, we used 60% allograft and 40% DBBM and xenograft. And our thought behind is that you see it as a GBR, but it's in an open GBR fashion. You serve along the regeneration wave of the body because you take out the tooth. There's trauma, there's bone growth, of growth factors released, etc. and that really helps with the healing. I should emphasize that when you extract the tooth, really take care that there is enough bleeding, of course, in the socket, because that's the basis of all. And we want to have stability. And if you also see for horizontal or vertical GBR, also the xenograph will help for the longer stability.
Perfect. Let's see here. Are there any undesirable effects when using a removable temporary prosthesis on top of the membrane for these cases?
No, as long as it doesn't push on it.
Yeah, you have to have complete relief. There can be no pressure on the side. Exactly.
Yeah.
Elaborate on the pre and post-op medication and any post-op instructions for these cases.
Yeah. Well, of course, rinsing. Rinsing will do for the first 2 weeks twice a day, or maybe the first 10 days twice a day. And then once a day. I don't like the brushing which some colleagues in the States do with the Q-tip. I don't like the micro movement because I want to have stability. So they rinse quite a long time. And of course, with antibiotics coverage, we are also now looking at local delivery of antibiotics in the graft, but we're studying this, so I can't make really final recommendations yet on those topics.
Okay, perfect. So I'll get here to the last question, and for the audience, if your question wasn't answered, we will try to get an answer from Dr. Vroom and email you the response there, which would be good to have that kind of direct interaction anyway. But the final question here is, can we use this technique when simultaneous implant placement is also occurring?
Yeah, I expected that one.
Sure.
We are a little bit conservative in our practice in a way. We're pushing the limits, of course, as you see with these cases. But I always like it to have first the bone and the tissues and then make the implant placement. But of course, there is a case report on it, and I just looked it up today because I expected this question. There's an interesting study from Gregor George Zavieropoulos, if I correct it rightly, and that's an article from 2020, and it was published in Medicina. But there they show also cases where they're covering up direct implant placement, graft, and then place a membrane on top of it, and they remove it after several weeks. There are indications for it, but I think it also depends on if you're more conservative or not.
I think it's a good point. From some of our other more conservative colleagues that we work with, the kind of the challenge to placing implants simultaneously with this type of graft is if you have any type of complication, it becomes much worse whenever you have the implant that's also involved now in the situation. So most of the time, and at Osteogenics, we're also as conservative as we can be. The suggestion probably is to take it easy. We can stage that and still get a good result. One thing that I want to mention is we will upload this presentation then to our YouTube page and also some social media, so everybody will have access to it there. But that really wraps us up. There's of course several other questions which Dr. Vroom will graciously help us answer, and we will get that to everybody. One final thing is we will have a survey that we will send out here shortly to get feedback from the attendees, and Dr. Vroom will provide you the information there. But to kind of wrap us up and close here, I want to thank you for your time, Dr. Vroom. It's been a fantastic presentation. Your answers to the questions here have also been gracious, and we appreciate you taking the time to spend with us there as we've gone over here a little bit. But overall, just want to really thank you and let you know how much we appreciate all that you're doing here for Osteogenics and also for your patients and the clinicians that joined us today. So thank you so much.
Okay. Thank you. And to all the participants, really consider this interesting technique, which doesn't get so much attention at big congresses, but it's great to work with, and you will be fascinated too. It's every time joy if you see the results. Yeah. So enjoy it.
Perfect. Thanks, everybody. Have a great rest of the day. Goodbye.